All right, hey everybody, good morning. Dr. Rafich here from Vet Triage. It is Thursday, January 9th, 2025, 10:51 a.m. Pacific time. And we got a lot going on this screen. First off, we're going through this Veterinary Surgery Journal, October 2024. Secondly, the picture there of the drawing of a dog lungs and intestines. That's an image of the cisterna chyli and thoracic duct, for those who don't know the anatomy of that. And their main functions are to drain lymphatics from the abdominal cavity. So you can see it's coming from like the small intestines there. And then it brings it up into the central venous system through the cardiovascular system. So you can see it goes from cisterna chyli, the lymphatic fluid flows from the abdominal cavity into the thoracic cavity where it becomes thoracic duct and then goes into the central circulation. And the bottom here, the chart below me, is a chart of all the reported success rates of chylothorax in dogs and cats. This is especially important if you're a vet student, and even more so if you're a veterinary surgery resident. You're going to need those numbers for your surgery boards. So this one is a paper on the lymphaticovenous anastamossis of the caudal thoracic duct in the azygous vein, a feline cadaver study. This study comes out of the university in Wisconsin-Madison Vet School. The objective is to describe a technique for anastomosis of the thoracic duct to the azygous vein using a microvascular anastomotic coupler device in feline cadavers. It was a cadaver study, 8 cats. They use a left paracostal laparotomy, so that gives you access to the small intestines, and a 9th or 10th intercostal thoracotomy. That 9th or 10th depends on the diagnostics they perform beforehand, which is lymphangiography that we'll talk about here in a minute. They injected contrast media into the mesenteric lymph node, and lymphography was used to identify the thoracic duct and its branches. The duct and the azygous vein were isolated, ligated, and divided with the aid of a surgical microscope. The thoracic duct and the azygous vein were anastomosed end-to-end using either a 1.5 millimeter or a 2 millimeter microvascular anastomotic coupler. Intraoperative patency was assessed by the manipulation of chyle and venous blood across the anastomosis. So because these are cadavers, there's no blood flow, right? And no lymphatic flow. So they had to literally push the lymphatic and blood fluid back and forth to make sure their surgery was successful. Mesenteric lymphography was repeated to confirm patency. The thoracic duct results. The thoracic duct was ligated via lymphography in 7 of 8 cats. The anastomosis was successful and patency was confirmed. The median and range duration for the procedure was 122 minutes. So it's about 2 hours, and it ranged from 80 to 150 minutes. The clinical significance of this paper is that alternative treatment for idiopathic chylothorax in cats by directly connecting the abdominal lymphatics to central venous system. The stimulus for collateral vessel development around the site of the thoracic duct ligation may be minimized, which may prevent leakage of chyle through more cranial lymphatics. All right, so introduction. Idiopathic chylothorax in cats is uncommon but serious. It results in the accumulation of chylous lymphatic fluid in the thoracic cavity. The pathology of terminal branches of the thoracic duct that disrupts the normal flow of chyle into the cranial vena cava occurs. Lymphangiectasia and the leakage of chyle in the region of the cranial mediastinum has been reported, which may suggest some degree of obstruction or alteration of the normal lymphatic flow from the thoracic duct as it enters the central venous circulation. So all this is to say that we don't know what causes chylothorax. Usually it's idiopathic. However, maybe some kind of obstruction or malfunction of the system. Chronic chylothorax in cats frequently causes fibrosing pleuritis, which leads to pleural thickening that prevents appropriate expansion of the lungs and has been associated with a guarded to grave prognosis. And you can see pleural thickening in cats that have any number of chronic airway diseases like bronchitis or asthma. You can see it on radiographs. Usually, not always. Perioperative mortality in other surgeries are up to 57%, and persistent chylosuffusion occurs in 60 to 80% of cats surviving surgery. So that's where you can reference the chart there below to see what the success rate was. And MST, for those who don't know, is median survival time in that chart. All right. The thoracic duct courses on the left side of the aorta in cats and on the right side of the aorta in dogs, and with significant individual variations, and branching is common. Previous procedures include surgical ligation of the caudal thoracic duct, ablation of the cisterna chyli, subtotal pericardectomy, or a combination. The goal is to prevent the flow of chyle into the craniomediastinal lymphatics and promote the development of acquired lymphaticovenous anastamossis in the abdomen, which will allow chyle to enter the central venous system and bypass leaky lymphatics in the cranial mediastinum. Lymphaticovenous anastomosis has been described as a treatment for people, including lymphedema and chylosuffusion of the abdomen and thorax. The duct has been successfully anastomosed with a variety of vessels, including the large thoracic vessels like azygous vein, external jugular vein, or other collateral veins. The microvascular anastomotic coupler device have been utilized to allow vascular anastomoses while minimizing technical demands and skills required to perform hand-sewn anastomotic techniques. Lymphaticovenous anastomosis of the thoracic duct to an intercostal vein has been described in both a cadaver and experimental study in dogs, and they found patency 30 days postoperatively. Materials and methods. Did a right lateral recumbency approach here, pericostal and intercostal, 4 to 5 millimeter left pericostal laparotomy to exteriorize the ileocecal-colic junction, and then the mesenteric lymph node was utilized to inject iohexol, or Omnipaque 300 is the product. They used fluoroscopy in both lateral and oblique images, both video and still. A left 9th or 10th intercostal thoracotomy was performed, and they used a surgical microscope for the procedure. When more than one thoracic duct branch was present, then the largest diameter was selected for anastomosis. At the most cranial extent, the thoracic duct was double ligated, and the adjacent azygous vein was isolated as far caudally as possible to the level of 10th or 11th intercostal veins, and that was double ligated. And they performed the end-to-end anastomosis of the two structures using either 1.5 or 2 millimeter microvascular anastomotic coupler. So here are some pictures. So the one with the blue glove, that's them placing a catheter into the mesenteric lymph nodes. They can inject the contrast material, and then where my hand is here, that's the x-ray. The black is the cisterna chyli, and the white is the venous system. And then you can see the intraoperative pictures there. Thoracic duct, azygous vein, and then intercostal arteries are the ICA. Ow. Okay. Patency was assessed by antegrade and retrograde manipulation of the fluid across the anastomosis. Postoperative mesenteric lymphography was repeated. And then here is the picture of the device. This is the device they're talking about. So they took that device and they placed it in between to anastomose the azygous vein and thoracic duct. So pretty cool. And then here it is on the x-rays. You can see they circled where the device is. There. Results. The cats weighed a median of 5.2 kilograms. The volume of contrast they used was a median of 12 milliliters. The caudal azygous vein was slightly larger than the thoracic duct, measuring between 1.5 and 2.25 millimeters in diameter. It is worth noting that in these cadavers, the thoracic duct was more compliant than the azygous vein when everting the vessel wall onto the pins of the device. It was successful in all 8 cats. 2 millimeter device was placed in 2 cats and 1.5 millimeter in the other 6 cats. And then they used fluoroscopy to confirm patency of the anastomosis. The median and range duration for dissection of the thoracic duct and azygous vein and anastomosing was 120 minutes with a range of 80 to 150 minutes. The duration of the separate portions of the procedure was 80 minutes for dissection, ranging from 55 to 105 minutes, and 30 minutes for the application of a device, which ranged between 20 and 80 minutes. Discussion. Current surgical techniques such as thoracic duct ligation combined with cisterna chyli ablation are designed to prevent lymphatic flow through the craniothoracic duct and promote the formation of acquired abdominal lymphaticovenous anastomoses at the site of cisterna chyli ablation. The acquired lymphaticovenous anastomoses provide an alternative pathway for chyle to enter the central venous circulation, avoiding passing through leaky lymphatics in the cranial mediastinum. However, formation of acquired lymphaticovenous anastamossis is inherently variable and in some cases may be insufficient to adequately decompress the abdominal lymphatic system. This may provide a stimulus that leads to the formation of collateral branches that could bypass the site of thoracic duct ligation and ultimately result in failure of the procedure. Regarding lymphography, a median of 12 mils of contrast agent was used, which is about 2 mils per kg. The typical iohexol dose is 1 mil per kg. Other lymphography techniques include injecting into the paw pad and using popliteal lymph node, which are less invasive alternatives to cecocolic lymphography in live cats. The use of computed tomography lymphography may provide a more accurate means, as it's been found to be superior to radiographs for identifying the branching pattern of the thoracic duct and providing greater contrast resolution. Regarding surgical technique, the surgical time tended to decrease over the 8 procedures performed as the learning curve improved. The time was less than 3 hours in all cats, and it's comparable to surgical time when you combine the cisterna-chylia ablation, thoracic duct ligation, and subtotal pericardectomy, which is what the majority of surgeons will do. They'll do the combination of three procedures, and you can see there that they have that reported at the bottom there. There it is: thoracic duct ligation, subtotal pericardectomy, and thoracic omentalization. Yeah, not great success rates overall. But the combination of the procedures is better than just doing one by themselves. One potential concern with the creation of a direct anastomosis between thoracic duct and azygous vein would be retrograde flow of blood from the vein into the duct, leading to bidirectional flow or clot formation. However, the presence of valves within the caudal thoracic duct and the normal contraction of smooth muscle within the tunica media are mechanisms that would likely prevent significant retrograde flow within the thoracic duct. The normal central venous pressure of -4 millimeters of mercury in cats is likely to create a negative pressure gradient between the azygous vein and thoracic duct, and therefore actually increase flow from the abdomen to the chest. Additionally, reports from humans and dogs that have undergone this procedure described no complications related to retrograde venous flow into the thoracic duct. And that's it. It's a pretty solid study. Obviously you'd want to have more cadavers, but it probably doesn't matter since 8 out of 8 is pretty good success rate anyway. Hopefully enough to try this in live animals. They do mention here, of course, that surgery may be more difficult in a live animal where you have like a beating heart and lungs are inflating and there's blood and all that kind of thing, anesthesia complications, etc. But this is a nice study, a nice start to it. So, all right, thanks everybody. Please subscribe and hit like and share and do all the things. See you.